Okay, perfect. Good morning, everyone. Sorry for the delay. We had some technical difficulty. The second part of the cardiac anatomy for the electrophysiology world. So I'll be continuing the presentation. This slide, we're going to talk about the AV fibrous tissue or skeleton. If we look here and if we cut the atria and look down the see the AV valves, the tricuspid valve here on the right, the mitral valve, the aortic valve, and the pulmonic valve. Each valve has the leaflets and the mitral annulus. Basically, each valve has an annulus, and these valves are connected with a fibrous tissue. So you can think of the heart as two top chambers, two bottom chambers separated by a fibrous tissue that does not conduct electricity. The only electrical connection between the top and the bottom chambers you have basically is the AV. Another way of looking at it as an atrial muscle mass, muscle, the AV fibrous skeleton and valves, and connected with one electrical connection, and that is the AV node. That is in normal cases. Of course, there are other possibilities of connecting these two muscle masses by accessory pathways that could be anywhere on the right or on the left. One thing to keep in mind, and that is the AV connection, AV nodal connection, is the only normal connection. This is a specialized tissue connection. So the AV node specialized in conduction and acts in a responsible way. It delays the electrical conduction between the atria and the ventricles to allow filling of the ventricles. It does not allow very fast heart rates from the atria in case of atrial fibrillation, for example, to go one-to-one to the ventricles. These smart properties of the AV node are not usually shared by the accessory pathways that are merely, you can think of them as muscle fibers connecting two muscle masses. They are not as smart, not as specialized, and they conduct very fast, and they can be a problem in case you have very fast atrial activity such as atrial fibrillation or atrial flutter, and conduct very fast to the ventricles and may precipitate ventricular fibrillation. Now let's talk about the atria. This is section throughout the heart with the four chambers. You can see the right atrium here, the left atrium here, the enteroatrial septum, the opening of the IVC, and this is the SVC. One thing I want you to look at and see how smooth the left atrium is relative to the right atrium. And the right atrium, you have a ridge here. We call it the Crista terminalis, which we'll talk about more in the few slides. Smooth part in the back and trabeculated or bundled part in the front. And also look at the left ventricle versus the right ventricle. The left ventricle thickness is much more than the right ventricle thickness, and that makes sense because the right ventricle is pumping the blood to the lungs, and the pulmonary pressure, let's say about 25 millimeter of mercury, versus the left ventricle dealing with the systemic pressure with systolic blood pressure, let's say about 125. So if you are pushing 25 versus 125, you can imagine why this muscle would be much thicker than the right ventricle muscle. If we open the right atrium and look to the medial side of the right atrium, you can see here the right atrial appendage, the tricuspid valve separating the right atrium from the right ventricle. And you can see the fossa ovalis, which is the membranous part, thin part in the intraatrial septum separating the right from the left. And this is the site where we do the transseptal procedure to perform procedures on the left side, whether related to mitral valve clip or atrial fibrillation ablation or Watchman device. You see the opening of the coronary sinus with the Thabesian valve, and I'm going to identify some important structures that are relevant to arrhythmia and ablation. So this is the same view with everything labeled. And I want to highlight this triangle we call the triangle of Koch. And that's basically bordered by the AV node on the top, the tricuspid annulus anteriorly, the coronary sinus in the back, and the continuation of the eustachian valve with the tendon of Tadaro. This triangle of Koch is very important because this is the site of ablation for the AV node slow pathway. This is a representation of the AV nodal reentrant tachycardia, where you have a reentry circuit using a slow pathway posterior to the AV node and going up the AV node, down the slow pathway, up the AV node, down the slow pathway, up the AV node. To stop that circuit, we usually go and target the slow pathway behind the AV node, and we try to spare the AV node so we don't damage it and we don't need to put pacemaker in. And this is another representation of ablation of the AV node slow pathway. This is an RAO projection. This is an LAO projection. When we do 3D imaging, we go in and we record His bundle in the AV node area. Every spot where His bundle is recorded is tagged, and this is His catheter. So this area is the area that represents the His bundle recording and the AV node area that we try to stay away from. This is the coronary sinus here, and this is the catheter, the duodeca. This is in the right atrium, and this is in the coronary sinus. This is an LAO projection. If you look in the RAO, the triangle of Koch would be in this area. And this is the area of the slow pathway where we apply catheter ablation lesions. And we try to stay at a safe distance from His bundle recording. In this case, it was 21 millimeter away. In this case, we had AV nodal reentrant tachycardia, and the patient was successfully ablated. On X-ray, this is what it looks like. In RAO, this is an LAO projection. In LAO projection, you have the His catheter, you have the CS catheter. This is the CS, you have the RV catheter, and this is the ablation catheter in the successful ablation site, positioned in the slow pathway area at the bottom of that triangle of Koch at a safe distance from His bundle recording. Another area I would like to highlight, and that is the Cavotricuspid Isthmus. This green zone here between the tricuspid annulus and the eustachian valve, or the opening of the IVC. In this area where we perform catheter ablation for typical right atrial flutter. If we have this diagram between these two lines, the IVC in the back and the tricuspid annulus in the front, this area we call the Cavotricuspid Isthmus, Cavotricuspid Isthmus. And this is the corridor, if you will, where the typical re-entry circuit of atrial flutter basically exists, and that can be counterclockwise or clockwise. Either way, it's still typical right atrial flutter. And for ablation, we basically perform lesions. This is basically the ECG of the typical atrial flutter we are all familiar with. And for ablation of atrial flutter, we create lesions across the isthmus, one dot at a time. And by creating those lesions, we stop the circuit and we achieve successful ablation. This is also the same idea, just trying to show you when we perform ablation, the tissue changes that happen. This is the tricuspid valve and the tricuspid annulus. The IVC is here, and this area is the isthmus. The ablation catheter is in contact with the isthmus, with the tissue. We apply the radiofrequency ablation lesions, and we pull the catheter one dot at a time until we create this scar here. This is the extent of damage we cause to the tissue. It goes from pink to pale. Pale means scar. Scar does not conduct electricity, so no circuit can go across, and that's the reason for the circuit to stop, and that's how we ablate typical right atrial flutter. Now let me highlight another structure, and that's called the Crista terminalis. And that is the ridge on the lateral wall of the right atrium between the smooth part in the back and the rough trabeculated part in the front. And why is it important? Because many studies have shown, this is one of them in 2006, that most focal atrial tachycardia come from the right atrium, and especially from this area, the upper crista terminalis. So it's important we know that structure, and at the top of that crista, that's where the sinus node is located. This is just a representation of focal right atrial tachycardia. Of course, the technology we have now with the 3D mapping and the timing that we can decide on activation on each part of the heart. In this case, you can see the right atrium here. This is the tricuspid annulus. This is the SVC, the IVC. The focus is in the right atrium. This is the left atrium. The earlier the spot, you get red, then you get yellow, green, and purple, and blue is the latest. The software allows us to achieve what we call propagation map, and that gives us the timing and the spread of the activation. And you can appreciate how this spot is focal, not re-entrant. You have one spot where the electrical activity starts and spread in all directions, and it gives you the timing. This patient had focal right atrial tachycardia that we ablated in this area successfully on the right atrium. For ablation of the WPW or Wolff-Parkinson-White syndrome, you have accessory pathways. As I mentioned, the accessory pathways could be on the right side or could be on the left side. Basically, they are muscle fibers that cross the AV valve annuli and could participate in re-entry circuit. And our job is to ablate those accessory pathways to stop that circuit from happening. And if we have to go on the left side, we do transseptal procedure. This is a typical 12-lead ECG of what we call ventricular pre-excitation. As I said, the accessory pathway between the atria and the ventricles is usually fast conducting, so you don't have the delay you usually see with AV node. The delay in conduction in the AV node is what gives us the PR interval or the PR segment. Here you see the P wave, and immediately after it, you have the QRS starting with a small area we call a delta wave. This delta wave is a result of activation of part of the ventricular myocardium down the accessory pathway. So if you look at the 12-lead ECG here, you do not see a PR segment. You have P wave and the QRS immediately after it. You finish activating the atria, and you jump right away to the ventricles through a fast conducting accessory pathway. If you are to ablate the left accessory pathway, we can do it one of two ways. We can go down the aorta to the left ventricle in the retrograde transaortic approach and ablate it, or we can go transseptally with the catheter to the left accessory pathway and ablate it that way. In this case here, we have the ablation performed transseptally. Again, this is an LAO projection. His catheter in the AV node area, duodec, the right side and the right atrium, the distal part and the coronary sinus, the transseptal sheath, and through the sheath we have the ablation catheter going to the accessory pathway. Just a reminder, all the ablations are performed with a beating, with a heart beating basically, and you can imagine what kind of challenges that can present regarding the catheter stability, and sometimes can be an issue to achieve success. Now we're going to go to the left atrial anatomy. This is a 3D reconstruction of the left atrium with its pulmonary veins. You have the left pulmonary veins on the left here, the right pulmonary veins, and this structure in the left atrial appendage. This is actually a 3D map we performed in one of our patients. The way we do it, we put the catheter inside the chamber, multi-electrode catheters of different shapes, and we sweep the catheter and every contact point with the left atrial wall or within the veins are connected to create a 3D structure of the left atrium, pulmonary veins, and left atrial appendage, and we use that as guidance for our catheter ablation in the left atrium. One thing I would like to highlight of the left atrial structure, these are different views of the left atrium. Let's just look at this, looking from the back. You have the left superior and left inferior pulmonary veins, right superior, right inferior. This is the appendage, and this is the right atrium with the IVC and the SVC here. Just notice how the atrial wall is simply bundles of muscle fibers, different orientation and overlapping. And I can show you this slide and you can appreciate the thickness of those muscle fibers. And as the veins enter the left atrium, you can see the muscle fibers are less dense at the contact or at the connection points between the vessels and the left atrium itself. So think of those muscle fibers as sleeves, as fingers wrapping around the pulmonary vein, trying to attach those pulmonary veins to the left atrium. So the muscle fibers are not the same density and they are not oriented in the same way. And as they go towards the connection with the pulmonary veins, they are not as dense. And actually this area of connection, of welding points, if you will, these areas are usually the source of a lot of ectopes that can trigger atrial fibrillation, and that's the basis for our ablation with pulmonary vein isolation to try to treat atrial fibrillation. This is another patient. We created a 3D map of the left atrium and its pulmonary veins, and we have multiple veins, 2 on the left, and we have 3 on the right, superior, middle, and inferior, and the anatomy could be very variable. In this case, for example, you have a common, again, we're looking from the back of the left atrium and we can see the pulmonary veins. These are the right, this is the left. In this case, you can see the left superior and left inferior joining in a common left pulmonary veins. Here they are separate and you have a middle right pulmonary vein, and sometimes you can have a branch pointing posteriorly here. So the anatomy could be very variable. That's why it's very important to create the 3D geometry and reconstruct that chamber and its veins and appendage for every patient. Now I would like to highlight the relationship between the esophagus and the left atrium. One of the most dreaded complications of ablation for atrial fibrillation is creating left atrial esophageal fistula. If we look at the CT scan here, this is anterior, the sternum, this is the back, this is the heart with the right ventricle and right atrium anteriorly. Posteriorly, you have the left ventricle and the left atrium. Immediately before the left atrium, you have the esophagus, this is the aorta. So look at the proximity between the esophagus of the left and the left atrium. And when we are creating lesions in the left atrial posterior wall, you can imagine those lesions can affect the esophagus as well. That's why we have esophageal temperature probe and in horizon temperature. That's when we stop ablation and we use a lot of care to try to avoid that complication. This is again to highlight how close the esophagus in the back to the left atrium here. The only separation really is the thickness of the wall and of the left atrial wall and the pericardium itself. No distance whatsoever, few millimeters in distance. So need to be very careful. And the esophagus, this is a 3D reconstruction. This is the left atrium with the pulmonary veins, and this is the esophagus towards the left. Could be more towards the left, more towards the right, or in the middle. And it could change in position actually in the same patient during the same procedure. Again, to highlight how close the esophagus as a structure to the left atrium. Actually, you can see the esophagus taking the shape of the posterior wall of the left atrium. Now let's move to the right ventricle. If we open the right ventricle, we can see the leaflets of the tricuspid valve. Attached with its chordae to the papillary muscles. The moderator band is that connection between the septum and the free wall of the right ventricle. From an electrophysiology standpoint, this is the area we need to focus on, and that is the right ventricle outflow tract. You can see how smooth that is, and that's usually the source of the right ventricle outflow tract PVC, and ablation is usually performed in this area. And a beating heart with a smooth part, also you can imagine why contact could be hard to achieve and why multiple lesions may be needed to achieve success. If you look at the trabeculation in the right ventricle here, you can also see why a pacemaker lead or a defibrillator lead could easily be trapped here. I'm not talking about the active fixation, I'm talking about the passive fixation leads, where they have tines at the end of the lead that can easily be hooked and trapped here. And the tined passive fixation leads used to be used a lot in the past. Now we use more of the active fixation leads. Moving along to the left ventricle, you can see the left atrium here, the left ventricle here, and the leaflets of the aortic valve. And in the left ventricle, you have a papillary muscle. We call it posterior medial here, posteriorly. And the other one is anterolateral. Each papillary muscle supports one leaflet of the mitral valve. We have anterior mitral leaflet supported by the anterior papillary muscle, and posterior mitral leaflet supported by the posterior papillary muscle. So I'll start with the aortic valve and highlight some sites that could be the target for ablation. This is aortogram limited of the aortic root, and this is the JR4 catheter moving between the right coronary cusp and the left coronary cusp. And the aortic cusps are usually the target for ablation of different atrial and ventricular arrhythmia, and I'll highlight these arrhythmias. So this is the non-coronary cusp in the back. This is an REO projection. Anterior to it is the right coronary cusp, and on the other side, the left coronary cusp. So you have three cusps. And we ablate in all three. So this is a TEE showing the aortic valve with the three cusps. In the back here, we call it non-coronary cusp because there is no coronary artery that comes off that cusp. You have the right coronary cusp, and you have the left coronary cusp. And you can see the opening of the left coronary artery here. The right coronary cusp gives rise to the right coronary artery. The non-coronary cusp in the back, there is no coronary artery that comes from it. The non-coronary cusp is the place where we ablate non-coronary cusp atrial tachycardia. In this area, where the left atrium, the right atrium, and the non-coronary cusp come together, could be the location where the focus for atrial tachycardia exists, and we can go in this area and ablate it. We have the option of ablating by going across the septum to the left side. We have the option of ablating from the right side, and we have the option of ablating within the coronary cusp. From the right side, we'll be potentially close to the AV node and risking damage to the AV node. We don't want to do that. From the left side, could be hard. The easiest first step is to go in the non-coronary cusp and deliver the energy in this area. Rare cases, we may have to go on the left side and on the right side to sandwich it to get that spot and achieve successful ablation. So the non-coronary cusp is the site where we may ablate focal atrial tachycardia. We call it non-coronary cusp atrial tachycardia. Now, do we ablate in the right coronary cusp and in the left coronary cusp? Yes, we do. And that's usually for PVC foci. So to ablate in the non-coronary cusp, although the non-coronary cusp is in the posterior area, we still define the os of the right coronary artery. And just to show you the relative relationship between the tip of the ablation and the non-coronary cusp in LAO projection relative to the os of the coronary artery, we're not only in a different plane, we're also at a safe distance from the os of the right coronary artery, which would be in this area. And this is REO projection of the same patient in the non-coronary cusp. And you can see the relationship between the his catheter on the right and non-coronary cusp location here. So you can imagine if we are to burn on the right side approach, how close we are to the AV node and to the his bundle recording area. This is the safest and the most successful area of ablation for non-coronary cusp. Now, to explain why would we ablate PVC foci in the coronary cusps. So this is the left ventricle, the long axis. This is the aorta, and this is the coronary artery coming off a coronary cusp. Here, this is the left coronary cusp, and this is the short axis of the left ventricle, like a donut here, and the right ventricle. Once again, we can appreciate the thickness of the left ventricle relative to the right ventricle, and the reason the systemic pressure is 5 times that of the pulmonary pressure in normal cases. So let's focus at the root of the aorta as it connects to the outflow of the left ventricle. If we look at the pathology of that connection, this is the wall of the aorta. This is the left ventricle muscle. This is the connection point between the wall of the aorta, which doesn't have muscle, to the muscle of the left ventricle. One thing we need to know, and that is the leaflet of the aortic valve insert in the muscle part. It doesn't insert here at the connection point between the aorta and the muscle. It goes down a little bit and insert in this area, lower than the connection point between the aorta itself and the left ventricle muscle. So this red zone could be the site of PVC focus. And that's why when we bring the catheter in this area, we can ablate within the coronary sinus, within the sinus of Valsalva or the cusp, we can ablate the PVC focus. And that's why we could ablate some PVCs from the left or right coronary cusp. Once again, we have to define the os of the right coronary artery or the left coronary artery before we ablate in these right and left coronary cusp to make sure we are at the safe distance. And this is an example of right coronary angiogram. The same picture, the same angle, and this is the tip of the catheter and the right coronary cusp. And you can appreciate the relative distance between the os, which would be here, and the tip of the catheter. That's a safe distance. This is the same catheter in REO projection. And you might say you're very close to the his. Yes, you are, but that distance with some fibrous tissue between is enough to achieve safety and not damage the AV node. Sometimes the focus could be between the right coronary cusp and the left coronary cusp. This is 3D reconstruction of the aortic root. This is the non-coronary cusp in the back, the right coronary cusp and the left coronary cusp. And sometimes the focus is in between the two. And this is the left ventricle alpha tract. And in that case, when you are in between the two cusps, you can imagine how hard it is to achieve stable catheter in that area. So that's when you have to prolapse the catheter, and the tip of the catheter will achieve enough contact to take care of that focus. I would like to highlight now the papillary muscles in the left ventricle. As I mentioned, the papillary muscles, the purpose of them is to support the ropes, if you will, that hold the leaflets of the mitral valve. Anterolateral papillary muscle support the anterior leaflet of the mitral valve. Posterior-medial support the posterior leaflet of the mitral valve. And you can imagine if you have a ruptured papillary muscle, if you have an infarcted papillary muscle, dysfunctional, ruptured chordae, why we would end up with mitral regurgitation. Again, another representation of papillary muscles, the posterior medial and the anterolateral. and that's the short axis showing these two papillary muscles. Why are we talking about them? Because both papillary muscles could be the source of PVCs and ventricular tachycardia, and you can have a focus in each one of them, and connection between the two papillary muscles have been noted, and that can create different morphology PVCs. And it's really hard to ablate those PVCs because of the structure, how deep those spots are within the papillary muscles, and how unstable the catheter as it touched those papillary muscles in a beating heart. And that's what we use. This is one patient we did with papillary muscle PVC and VT. On the right here, you can see the left ventricle, short axis. You can see defining the papillary muscle on the left. You can see those papillary muscles drawn and the lesions at the tip of those papillary muscles applied. And the way we accessed the left ventricle here was by transseptal approach. You can appreciate this transseptal here going to the left atrium, the white mesh, and these are the two papillary muscles, and these are the lesions we applied. It is almost a rule you're going to end up with a lot of lesions to achieve success for papillary muscle VT or PVC. This is rendering of all the major anatomic structures in the heart and the great vessels. From one patient we had CT angiogram on, understanding the relationship between the different chambers, the vessels, and the structures, and their relationship to the different arrhythmia we treat is crucial for success and to do it safely without complications. And this is the end of the talk. Any questions?